EKG of the week. Let's walk through another real-life EKG. This one is just a little bit tricky. It might be a little bit subtle, but we will work our way through it here. So as always, go ahead and take a few minutes, pause the video, take a look at this EKG, and come back when you have an interpretation. And hopefully that's given you enough time to walk through this thing. Let's go through our standardized approach to them so that we don't miss anything. So looking at this EKG, overall, nothing like sticks out at me right at the beginning where my eyes are sort of drawn to, so let's walk through it. First, rate. Let's look at rate here. So we see counting across the bottom, we'll go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, and just about 11 beats. So multiply 11 by 6, that gives you about 66, which the computer says 64. All right, close enough. Good deal. Normal rate, let's call it that. How about rhythm? When we look at the rhythm, let's look at P waves, and does each P wave precede a QRS, and does every QRS follow a P wave? And we can look down in like lead, let's say lead 2 down here in the rhythm strip, since it gives us 2 rhythm strips on this one, both in lead 2 for some reason, just the way the machine was set. But when we look through there, so we say a P wave, QRS, P wave, QRS. Hard to tell on that one. Tough to see. This looks like maybe a P wave here. It looks a little different though. If you remember though, these were upright P waves, still upright, upright. That one is negative. And there's still a QRS that follows it, so I still think it's a P wave. But that P wave looks a little funky as well. If you remember, the other ones were sort of a smooth, upright little normal looking P wave. This one looks a little bit jagged. It's a little pointy. This one's, again, upside down, assuming it's a P wave. Here's another smooth one again. Another smooth one almost looks a little biphasic. Maybe a little more pointy on that one. So we see some P waves, and each QRS appears to follow a P wave, so we think it's probably a sinus rhythm, or is it? Because each of the P waves also, the number of them look a little bit different than others. You can look in lead 3 and kind of see the same thing. There's a P wave there, and there's maybe a little different looking P wave here, and there's a different looking P wave here, one that's almost essentially flat. And from beat to beat, that P wave looks different than that P wave, and it looks markedly different from each other. So I'm going to go ahead and call this, it does appear to be a what would you call it, a supraventricular rhythm, meaning it's not coming from the ventricles itself. But I'm going to go ahead and make the call here that this is a wandering atrial pacemaker, or the WAP. What's a wandering atrial pacemaker? Well, sometimes your atrial tissue, normally your conduction comes from the sort of top, body right part of the heart down across the atria to the AV node, and then goes down the septum and then out to the ventricles and kind of back up and around. And that's how you get your normal morphology. But the beat itself comes across from the sinus node, generally speaking, down across the atria. Sometimes some people's atrial tissue gets a little stretched out over time, and so you often see this with things like advanced COPD, where their atria are always kind of chronically full because their lungs are so distended, the blood can't pass them real well, and that kind of stuff. Reason's not all that important, but especially folks, again, with like COPD that are of advanced age, you'll see this happen sometimes where other bits of atrial tissue start creating P waves, and those P waves propagate just like they always would and go down to the AV node. So it's still a rhythm that comes from above the AV node, but it doesn't necessarily come from the sinus node every time. And so that's what you see here. When you see different P waves, different morphologies, you have, in this case, a wandering atrial pacemaker. You have one that, say fires off more or less normally up here, or maybe it doesn't quite fire off normally. We don't even see one here. We're not sure where that one is firing from, but it's a normal looking QRS. We see maybe a little small inverted P wave here. We see a real sharp P wave here. So in each case, and you notice too, the PR interval is a little bit different with each of these as well. So from different locations in the atria, there is some ectopic tissue that is firing off P waves, essentially. So that's a wandering atrial pacemaker. Now you notice his heart is still okay. He's still beating normally, and this isn't really the guy's problem per se, but it's just an interesting finding. It's not truly sinus rhythm because it's not coming from the sinus node. It is a wandering atrial pacemaker. And you know that because it's got I counted at least 3 different morphologies of P waves that you find here, the little pink one, the little green one, and then the red one that you find over on the end. So, wandering atrial pacemaker. Don't see that real often. When you do see it, it's probably going to be in an older person with fairly prolonged advanced COPD. By the way, when you're looking at the diagnosis of what the differential for what is an irregular rhythm but not fast, there's not that many things in it. It could be AFib, it could be a flutter with a variable block, could be AV block of some kind. These are all irregular beats. What makes the heart beat irregularly but not necessarily super fast? Those things, sinus arrhythmia, and then the one that you don't see real often is that wandering atrial pacemaker. So that fits in with our differential diagnosis for irregular and not fast in terms of your rate and rhythm. All right. So we said we think this is a wandering atrial pacemaker, and for what it's worth, cardiology agrees with me. Let's look at the axis real quick. So if we look at the axis, we go lead 1 looks primarily positive. So it's going in the direction of lead 1, which is right shoulder to left shoulder, essentially. So that seems right. It's essentially in lead 2 here, isoelectric, meaning there's about as much above the baseline as there is below. So it goes in a essentially perpendicular direction to lead 2 is what that means. And then when you get down to AVF, it's also still mostly isoelectric, although it looks like it's a little more negative in terms of the total volume. So I'm going to call it negative in AVF. So positive in 1 and negative in AVF puts you over in the kind of borderline territory. Perpendicular to lead 2 essentially gives you a axis of like negative 30 degrees, which is, again, borderline normal, almost left axis deviation, but we'll call it normal. And again, if you don't like axis, then it's usually not terribly helpful in this case, but we'll call it borderline normal here. How about the intervals themselves? We mentioned before we have variable PR interval. And each one is a little bit different, which we're going to attribute to that wandering atrial pacemaker, but it doesn't actually look like it's really ever a true block. When you look at the QRS complex, you do find that it looks wide. So again, our number is 3 little boxes to be a normal QRS, and it goes 1, 2, 3, and a shade above, maybe a quarter box above, 3 little boxes. If it's greater than 3 little boxes, it is a wide QRS, and this is a wide QRS. And so we'll ascribe to that. If we look at the morphology, there's not actually that true RSR prime wave here, where you would look for a right bundle branch block in lead V1 here. Normally you would expect to see that sort of M pattern in a right bundle branch block. We don't see that here, although it kind of suggests it's there. V6 kind of has that little hook like you might find in a right bundle branch block, but it's not definite. And it doesn't look like a left bundle branch block. So in a wide complex QRS, without one of those obvious morphologies that we can call left bundle or right bundle, I'm going to call this non-specific intraventricular conduction delay, or non-specific intraventricular block, meaning something's not going exactly right in there, but it doesn't just fit quite those little criterias. It's a little bit right bundle-ish is what I would refer to it as. So rate, rhythm, axis, intervals, and blocks. Let's look at ischemia and infarcts. What do we see? Any signs of ischemia, i.e. ST depression? Not a whole lot in the precordial leads here, and I certainly don't see any sign of ST elevation in the precordial leads. None there. If I look over in the limb leads, lead 1, no ST depression in the laterals. T-wave is inverted here. That doesn't necessarily mean a whole lot in AVL, and certainly, again, no obvious ST depression or elevation here. So let's say we don't see any obvious ischemia here. The one thing that we do see is looking at lead AVL. We do see a Q wave here, which is not entirely normal. We see a Q wave in the septal leads as well. So this may indicate, is old infarct, not one that's actively happening, because it takes, again, hours to days to develop Q waves after you infarct. But a Q wave that's in a place where it's not supposed to be is a sign of an old infarct, generally speaking. And then in terms of any patterns, just from pattern recognition, when I look at lead AVL, I notice that the R wave is pretty tall, and it's just usually not tall in AVL. That's just from looking at a whole bunch of EKGs. But you notice that the complexes down here, just from a broad standpoint, in V5 and V4, almost are big enough to touch each other. And when the complexes on two lines of the EKG are big enough to touch each other, that's usually a sign of LVH. And it does meet criteria for LVH in this one. So left ventricular hypertrophy is the pattern that you would expect to see here. Or sorry, not that you would expect to see, that you see here, and we expect LVH to be present in the heart. So we have a normal rate. We have a wandering atrial pacemaker, which is the big finding here. We have borderline left axis deviation for what it's worth, if it helps you at all. There's, again, sort of a variable PR interval with a wide complex QRS. There's a right bundle branch sort of block or a nonspecific intraventricular block, signs of an old infarct somewhere in there, and then a pattern of LVH otherwise. So overall, I'm going to say that the overall impression of this one is left ventricular hypertrophy and a wandering atrial pacemaker, but no obvious ischemia or infarcts. Whatever has gone on with this person's heart, it's probably been long-standing, probably not anything that we are just noting for the first time today, most likely. That is our EKG of the week. If you like it, like us on the YouTubes, and check out EMS Grand Rounds for other educational videos pertaining to the pre-hospital realm. And otherwise, we will see you next time. Thanks for tuning in.